This module, we're going to be talking about special circumstances. I'd like to remind you that it's important that you're open and flexible, and anything I say here that makes you anxious or nervous, take it with a grain of salt. Induction is this term that we use to artificially start or speed up labor and birth. Induction isn't inherently wrong or bad. Context really matters. The reason why many people would like to avoid medical induction is because it can lead to a cascade of medical interventions. The more interventions there are, the more of a delicate balancing act it becomes between mom's body and the baby. And the truth is, nobody knows how your body or your baby are going to react to certain medications. I would say induction gets a bad rep because people are really resistant to using the medical interventions, but there are real reasons that someone might need to be induced. I think it's important that you have a conversation with your provider, and if they are not giving you a real medical reason, for example, they're going out of town, or they're saying, oh, you're 40 weeks, you should just have your baby. These are not real medical reasons. Some of the more general reasons someone might need to be induced are pre-existing health conditions. For example, diabetes, high blood pressure. If baby is showing signs that they have stopped developing in utero, if the placenta stops functioning, if baby isn't breathing properly, or if we see a lot of heart rate decelerations when you go in for a prenatal visit. These generally are signs that say, okay, maybe you need to meet your baby sooner rather than later. If it's an elective induction, that means your doctor is suggesting you be induced, but there's no medical reason saying that it's necessary, and that is definitely something that you need to consider. So here are some interventions: vaginal exams, membrane sweeps. A membrane sweep is when your doctor goes in through your vaginal canal and sweeps the membranes along your cervix in order to create contractions. It can be helpful, especially if you're facing a deadline of possibly needing to be induced, or if your doctor is suggesting you need to be induced. You can certainly try for a membrane sweep instead of going for a traditional induction. Midwives use something called the Induction brew. It's a recipe. Basically, it has some herbs, some castor oil, and you chase it with a juice of some kind, and it causes uterine contractions. You can also artificially rupture your membranes or your amniotic fluid, and this is using an amnio hook. Essentially, your provider breaks your bag of waters for you, and the theory is that if your water is broken, it can speed up labor. Other important interventions used in an induction are the cervical ripeners. They are Cytotec, Cervidel. Essentially, they soften the cervix, and when they are softening the cervix, they can also cause uterine contractions. The main intervention used in a medical induction is Pitocin. Pitocin is a synthetic medication that mimics a hormone that your body naturally produces, which is called oxytocin. If you don't have any oxytocin in your body, then we need to use Pitocin, which essentially causes uterine contractions. There are some pros of getting an epidural. Number one, they allow you to get rest. So if I've had a client that has been in labor for a really long time, unmedicated, they haven't gotten any rest, and the end of labor is nowhere near in sight, it might be supportive to them to get an epidural so that they can regain their energy and birth their baby. There are cons associated with getting an epidural. Epidurals can definitely cause labor to slow down or stall. What do I mean by that? Well, the epidural relaxes the uterus. And when the uterus is so relaxed, the contractions might go away. And if the contractions go away, Your doctor might suggest the use of Pitocin, which is that synthetic medication that causes uterine contractions. Not everyone that gets an epidural needs Pitocin, by the way, so don't assume that just because you get an epidural, you're going to have Pitocin. But if you do get an epidural and your contractions do slow down or stop completely, and you're in the middle of labor, it might not be the end of the world or such a bad thing to get Pitocin. Epidurals also cause swelling, and sometimes that can affect someone's milk supply from coming in, so there might be a little bit of delay in terms of breastfeeding. It's not impossible, but it can be helpful to know that so that you're mindful of it and continue to stay hydrated after delivery. There's also a small chance that an epidural isn't placed correctly or just simply doesn't work on a person. I've definitely encountered that a couple of times. It's not a common occurrence, but it is worth noting. When you consent to getting an epidural, you're consenting to get a urinary catheter placed, to wear continuous monitoring bands around your belly to monitor you and your baby. You're also not able to get up and move around anymore, so you stay in the bed. There is no thinking involved when you want an epidural. You know you want an epidural now, and you're able to say that and voice that in between contractions. If you're in the height of a contraction and you say, I think I want an epidural, that could be you trying on the idea or simply coping through that contraction, which is fine. But you let your nurse or your doctor know that you want an epidural when you're not having a contraction. Epidurals must be administered by an anesthesiologist, and they can come administer an epidural at any point in labor. I've even seen clients get it at 9 centimeters, but if you make it to 9 centimeters, the odds are you don't need an epidural. When an anesthesiologist administers an epidural, you have to stay very still, and they place it in between contractions. It feels like a bee sting, and for clients that have gotten an epidural, they have said that the placement of the epidural is like nothing. It's no big deal because so much is happening. Essentially, that anesthesiologist is threading a very tiny catheter into your spinal space, which is sending continuous medication, which temporarily numbs you from the waist down. When I first started as a doula, when someone got an epidural, it was like they couldn't feel anything, and it made the pushing stage really difficult because they had no connection to their pelvis. But now when people get epidurals, you have enough sensation that when you start to get closer to pushing, you start to recognize that the sensation has changed, and also your epidural does not numb you at your vaginal opening. Once that baby is low enough, it goes beneath where the epidural is placed. So you'll still be able to feel something, which is helpful when it comes time to push. Some of my clients prefer to use a walking epidural to start because yes, it allows you to walk. Whereas a traditional epidural, once it's placed, you are stuck in the bed. Additionally, you have a urinary catheter placed so that you don't have to get up and use the restroom. They put the urinary catheter in after your epidural is placed, so you don't feel it going in, you don't have to worry about feeling anything. In the hospital, they use something called a pain scale, and the nurses will often ask you, on a scale of 1 to 10, how intense are your contractions? And if you tell them anything above a 0, they might suggest a medication to help you. And just because you're feeling intensity doesn't mean you need medication. So you just need to communicate with the nurses, hey, I'll let you know if I want pain medication. Please do not offer it to me. The other pain medications that are offered in the hospital, I usually do not recommend, and I really don't think they're appropriate for any healthy pregnant person. That is opiates and narcotics, Stadol, fentanyl, morphine, Demerol. What hospitals assume is that enough time will pass in labor, that medication will leave your bloodstream and leave your baby's bloodstream. But I have seen firsthand mothers that have chosen to get a narcotic and labor goes fast. Mom had her baby and the baby came out and literally was drugged. What's interesting is many countries don't even offer narcotics to pregnant people. In a country like the United States, where we have such an issue with narcotics in general, I'm not sure why we even offer it to a healthy pregnant person. There are other interventions that are sometimes used in a medical setting that are nobody's first choice, and yet they may allow someone to have a successful vaginal delivery. That might be through the use of a vacuum or episiotomy. An episiotomy is cutting along the perineum or the vaginal opening to create space for baby's head. Sometimes a provider may need to add hydration back into the uterus in order to keep going in labor. Sometimes antibiotics are necessary. Maybe mom spikes a temperature in the middle of labor because her water has been broken for hours and hours. Sometimes that happens and a round of antibiotics might be necessary. A cesarean is considered another special circumstance. It is not considered normal, healthy, physiological birth, and it requires a surgeon in order for you to have your baby. I'm not going to go too deep into cesarean births, but there are a couple awkward moments that I think is important for you to know about so that if for some reason you find yourself in the scenario of needing to have a cesarean, you don't freak out or feel scared or nervous. The first awkward moment in a cesarean birth is there's a surgical prep time that happens before the surgery begins. Usually that takes place in the OR, and the birthing person goes into the OR while the birth support person or the partner has to wait outside the OR. Usually that surgical prep is about 45 minutes. They make sure that the birth person is properly anesthetized. And if it's not an emergency cesarean, you should be awake for the procedure. You might feel a little loopy or out of it, but you should be awake to meet your baby. Only super rare circumstances would a birthing person need to be put under general anesthesia. More than likely, you are going to have local anesthesia or a spinal epidural. Once they finish with the surgical prep, your partner will come into the room and they stand near your head and you will be able to see each other, talk to each other. Sometimes that makes the experience a little bit more comfortable. Once they begin the surgery, it takes roughly 6 minutes for you to meet your baby. Generally, there's a curtain that separates your torso. They will show you your baby over the curtain. Then they'll bring the baby over to you for a brief moment of skin to skin. The second awkward moment after you meet your baby is they need to assess that the baby is breathing well, is nice and pink, is responsive to touch. This is called an APGAR score, and it happens at 1 and 5 minutes. And it's a rating from 1 to 10. We care more about the 5-minute score than the 1-minute score because sometimes it takes a baby a couple of minutes to start utilizing their lungs, especially if the umbilical cord is still attached. Once the baby is assessed and everything is healthy and normal, dad and baby come back over to mom. They are stitching you up. It is best practice to do a double layer sutures. The awkward moment here is that I've had clients describe the stitching as this kneading sensation. I had one client once say that it felt like a cat was kneading on their belly. If there's a special circumstance and your baby needs to go to the NICU, then your baby and your partner will go to NICU together because either you or your partner need to be with your baby at all times. So in that event, it can be really helpful to have a support person like a doula or a relative present. If your baby is healthy and everything is normal, then your partner and your baby will come back over to you and the three of you leave together and you go in a post-op recovery room. The post-op recovery room is usually not a private room, but there's a curtain that separates you from other patients that have also given birth in the OR. You then are transported into your postpartum room, and that's the room that you stay in until you leave and go home from the hospital. If you're having a vaginal birth, you most likely would stay in the hospital anywhere from 12 hours to 24 hours. If you're having a surgical birth, you most likely will stay anywhere from 48 to 72 hours. There are natural ways to induce labor as well, but none of the natural ways work unless your body and your baby have some level of readiness. You can do all the things and labor still won't start if your body or your baby are simply not ready yet. The first thing that you could try is eating dates. That's a really popular one. I've already talked about it in another module, but just be mindful about how many dates you eat daily because there's a lot of sugar in them. You can also try acupuncture. Acupuncturists are really skilled in certain pressure points in the body, particularly on the feet, that can cause uterine contractions. A good chiropractor can be helpful to start to prepare the body for labor. Taking stairs, walking, or hiking uphill, you are utilizing your pelvic floor muscles, which can bring on contractions quite strongly. So a daily walk, 45 minutes to an hour, at the very end of pregnancy can be really supportive and helpful for you to go into spontaneous labor. You could try nipple stimulation, which there are tons of videos out there explaining how to do that, but essentially you are mimicking the suck of your baby on your breast before baby arrives. Some people even try pumping. If you do these methods, check in with your provider. Sometimes it can bring on contractions pretty immediately. Usually if I have a client that wants to try this method, I usually advise try it for 15-20 minutes and then wait several hours before trying again. Because we're trying to produce oxytocin naturally in the body, doing activities that make you feel calm and relaxed can be really important. So trying to have sex if that makes you comfortable. Listening to a podcast, watching a movie, the more in your head you are, the more you try and cling or control how your labor starts or how your labor ends, I would say the harder your labor goes. Now, there is another medication that is used to help cope with contractions, and that is nitrous oxide. Not every birthing location has access to nitrous oxide, so definitely check with your provider. But essentially, it's a tank with a little mask, and every time you have a contraction, you take the mask and you breathe into it, and it makes you not care about the contraction. Are you still feeling the contraction? Yes, but it just takes the edge off. I was at a birth once in the hospital, and my client was entertaining getting medication, and the nurse said, "Oh, we'll get the anesthesiologist to come in and do an epidural." And I said, "Wait a minute, you guys have nitrous here, right?" And she said, "Yeah, but that's not pain medicine." And I looked at her, I said, "Okay, I think she would prefer to try nitrous first as it's way less invasive and could be a really great way to cope through contractions." There are many ways to cope through contractions, and if you need medication, by all means, that is a choice you can make. But there are other things you can try too first if it feels more comfortable for you. The first thing is understanding that contractions are only 1 minute long. The super intense contractions are 60 seconds long, and of those 60 seconds, really only about 15 to 30 seconds are super intense. You can do anything for 15 to 30 seconds. The hospital has a weird pain scale for pain management that I find is not usually helpful for pregnant people. Essentially, they ask you on a scale of 1 to 10, how much pain are you feeling? And the thing is, birth is designed to make you feel something. Whether you have an unmedicated birth, an induction, or end up in a cesarean, you are going to feel something. Whether or not you internalize that as pain is entirely unique to you, but the pain scale is really misleading, because if you tell your nurse, oh, my pain level is at a 4, they're going to do everything they can to get it to a level 0. They don't want you to feel anything. And it makes them uncomfortable when you are uncomfortable. And so as long as you're able to be strong and say, listen, I will let you know if I need medication. Thank you for offering it to me. You do not need to offer it to me again. Then you are claiming that space and you are saying, I'm in charge here. Midwives approach pain very differently. They are affirming, yes, you're feeling intensity. This is good. Hands-on labor techniques can also really comfort someone through the intense contractions. So working with your partner to figure out what makes you feel calm and relaxed. You can show them that, hey, I just need you to witness the hard work that I'm doing. I just want you to be present for me now. Breathing is such a good way to cope through labor contractions, and there are so many different ways to breathe in labor. The important thing is that you continue to breathe and not hold your breath. So if I see a client doing this, then I know that she's holding so much tension in her abdomen and in her pelvis. So breathing in through the nose and out through your mouth like this. Is really great and effective. You can invite your partner even to help support you by counting on average how many breaths it takes you to get through a single contraction. Another style of breathing is pretty old school. My mentor calls it rib cage breathing. I know they used it in Lamaze back in the day. It's just a he, hu, and it looks like this. Another style of breathing is just called tonation breathing. And yes, it is exactly that. You have one tone or one note, and that brings you through the entire contraction. And it sounds like this. Ah. Yes, I know. It looks silly, especially if you're not in labor, but I promise you, I have seen it help so many of my clients get through the intense contractions. There's also box breathing, which is this concept of inhaling for a certain number of counts and exhaling through a certain number of counts. True box breathing, you hold your breath at the top, but in labor, I don't recommend restricting your breath at any point, because we want to cleanse the breath in and out of our bodies so that we're not holding or gripping on to anything within the body. In through the nose for 3 to 4 counts and out through the mouth for 3 to 4 counts. So it just looks like this. I recommend that you have a birth preferences document where you can organize all of your preferences in one place, whether you have a hospital birth or plan to give birth out of the hospital. And if you're having an out-of-hospital birth, if you took the time to make your birth preferences, then you can take it with you if for some reason you need to transfer to the hospital. After your baby is born, if everything looks healthy and normal, your baby should go immediately on your chest. And there are early interventions that are available to you. The first one is vitamin K injection. Newborns are not born with any vitamin K or sufficient levels of vitamin K. Vitamin K is actually necessary to prevent excessive bleeding or hemorrhaging. So many providers recommend that you get the vitamin K injection, or alternatively, there are some providers that offer an oral medication of vitamin K, which is given at the same time every day for several weeks. You want to make sure that you put on your birth preferences, yes, I consent to vitamin K, no, we will waive our rights to receiving vitamin K. As a doula, I would say this particular intervention most of my clients choose to receive. The next intervention is called erythromycin. It is an oil-based antibiotic that is put in your baby's eyes that prevents them having a response to a sexually transmitted disease, more specifically gonorrhea or chlamydia. If you've had prenatal testing, you will know if you have one of these sexually transmitted infections. If you do, it is recommended to get the erythromycin eye ointment, because if your baby is born vaginally and you don't give them the eye ointment, there is a strong chance that they could go blind. I have clients that know they don't have gonorrhea or chlamydia, but they choose to get the erythromycin anyway because it's not an injection. It doesn't hurt the baby per se, but it certainly affects their vision temporarily, and their vision is not really strong at birth anyway. The next intervention is the hepatitis B vaccine. The hepatitis B vaccine is offered immediately at birth. However, you can delay it up to several months if you so choose. Hepatitis B is only contracted from someone that has an active infection. An active hepatitis B infection is contracted through either blood or semen. So as long as you know that your baby is not interacting with or being cared for by someone with an active hepatitis B infection, it is absolutely an option to delay it and get it with your pediatrician at a later time. If you have a home birth, your midwife has access to these medications as well, and a lot of pediatricians do too. Remember, after your baby is born, you are going to have to see your pediatrician. I always tell my clients to try and push that appointment off as much as possible in order to allow you time to acclimate to your baby, to bond, and to heal from birth itself. Obviously, if there are special circumstances, you might want to get to the pediatrician sooner rather than later. A lot of times pediatricians will want you to come in immediately, and that's because it works best for their schedule, but it might not be best for you as a new parent. If you have a boy, there's some choices you get to make with that, whether you want to circumcise or not. I will just say this: make sure that it's a decision that is yours and your partner's alone. If you're having a girl, I think it's important to mention that as her hormones begin to regulate for the first time, you may notice that she has a little bit of bleeding from her vagina. It is temporary, and it is the only time you will see that until she goes through menarche. Something else I want to mention about Pitocin is that it is often routinely given after delivery. So in postpartum, the immediate postpartum period, so after you deliver your baby and before you deliver your placenta, they often administer Pitocin. And the reason for that is to prevent postpartum hemorrhaging. So if you have questions about receiving postpartum Pitocin, please talk to your provider about it. If you feel any red flags about your provider, if you start to notice, oh, wait a minute, that doesn't feel right to me, and you dismiss it, or you pretend it's not there, or you're so close to your due date, you just don't want to think about it, you just want to ignore it, I would say that any red flags you have prior to going into labor are only going to get louder and more intense in labor. Write down your red flags. Talk to your provider about things that are bothering you. This is your experience, so claim it. You can ask your provider to show you the proof of what is the special circumstance that is leading them to believe that you need any sort of medical intervention. For example, if it has to do with the baby's heart rate, have them show you on the monitor where they are seeing the problem. If it has to do with you as the mom, have them show you the proof. Is it your blood pressure? Well, where is your blood pressure? Is it your temperature? Show me my temperature. And are there ways to mitigate it without giving medication immediately? I've never had a single client that switched providers come back to me later and say that they regretted it. But I have definitely had clients come to me later that wished that they had switched providers, that they had just honored the red flags and done what might have been a little inconvenient in the 11th hour and switched to a better provider. I have attended so many hospital births where my client was told by the nurse, okay, stop pushing, the doctor's not here yet. If I'm your doula and I'm with you, I would say to you, you need to do what your body is telling you to do. There are plenty of people with hands that can catch your baby. Let me reiterate how important it is to choose a doctor that you know and trust. If for some reason you don't have a positive experience with your doctor or with your midwife, I highly encourage you, after the dust has settled, when you're out of the immediate postpartum period, which might be 3 or 4 months, leave a review, because people read them. Other moms-to-be deserve to hear your story, especially if it wasn't a good one. Those matter. And I think a lot of providers are banking on the fact that a new mom is too busy or too tired to go back and leave a review about how they mishandled care. Thank you for bearing all of this in mind. From here on out, we are only going to talk about healthy, normal, physiological birth.